Welcome to Studying for FRCS. This is my YouTube channel, which is a supplement to the podcast by the same name. This is to help our preparation for FRCS examination, particularly general surgery. So today we're going to talk about a short presentation of fecal incontinence and a recap of its management. So fecal incontinence, quick incidence, most commonly it's idiopathic. 22% are iatrogenic, 15% due to obstetric trauma, and interestingly now, pelvic surgery and post-anterior resection comprises of about 13% of the incidences that we can see. So whenever we see a patient of fecal incontinence, we have to start from history. The duration of the symptoms, what was the previous bowel habit like, and also exclusion of red flag symptoms whenever we take any history is important. The particular attention should be paid in incontinence of flatus, liquid or solid stool, the impact on quality of life, previous obstetric history in female patients, that is vaginal delivery, prolonged labor, forceps or tear, in male patient or in all patients, any previous perineal procedure done, history of inflammatory bowel disease, chronic diarrhea, trauma to spine, congenital abnormality, and overall performance status needs to be assessed. On clinical investigation, abdominal, perineal, and neurological examination should be done. Inspection to see any fissure, hemorrhoid, excoriation, or evidence of soiling. Anus, whether it's closed or patulous. Any prolapse or perineal descent present when patient is asked to strain. On DRE examination, the resting anal pressure and the squeeze pressure needs to be assessed, and also whether any sphincter defect is felt. Sigmoidoscopy or proctoscopy to see rectocele and rectal intussusception. We have to exclude any visible rectal prolapse, rectovaginal fistula, cloacal deformity, and evacuation disorder. There are two calculators or scoring system that we use to quantify the burden of fecal incontinence on the patient. The commonly used are Wexner calculator and St. Mark's calculator. After we do this, we have to do some sort of imaging investigation, first of all, to rule out any pathophysiology. It can be either flexible sigmoidoscopy or colonoscopy. And then we proceed to anorectal physiology test. And this is just a quick recap because often it is found to be most confusing. Endoanal ultrasound, this will assess the anatomy of anal canal, defect and volume of the sphincter muscles. Anorectal manometry, where a small catheter is passed through the anal canal into the rectum and the actions of anorectal muscle functions are measured in real time in 2D and 3D setting. Difficography, where a continuous series of X-rays are taken during a bowel movement to identify any structural or functional problems in the anus, rectum, or pelvic floor. A thick barium paste is usually inserted into the rectum to stimulate the bowel function. If there is also MRI proctography, can be used instead of this. And pudendal nerve motor latency test. This measures the delay between the electrical stimulation of the pudendal nerve and the EMG activity of the external anal sphincter. The pudendal nerve is stimulated as it passes over the ischial spine using a specially designed electrode attached to the index finger of the assessor in the rectum. So normally what happens in a bowel motion? When content moves into the rectum, it increases the rectal pressure. This triggers an involuntary relaxation of the internal anal sphincter. This is known as the recto-anal inhibitory reflex. If we are not ready for defecation, then the external anal sphincter contracts to hold the content in the rectum. For defecation, the rectal pressure is then increased by abdominal contraction while anal sphincters relax to push the content through the anus. So what are the findings we expect? In EUS of the anal canal, we might see a sphincter defect. It is important to identify the sphincter defect as of what degree it is, but is more than 90 degree, less than 90 degree. In anorectal manometry, this is commonly most people find confusing, especially examinees. So in anorectal manometry, we measure four things, and there are four maneuvers. So first of all, resting pressure of the anal canal is measured, and patient is asked to remain still for 30 seconds when we insert the balloon catheter. After we insert the balloon catheter, this is where we take the baseline pressure measurements. Then ask the patient to squeeze, and so the patient is asked to squeeze the anal sphincter, and this is where we measure the squeeze pressure. This is the squeezing strength of the internal and external anal sphincter. Then we ask the patient to push, which will simulate defecation. So an increase in rectal pressure and relaxation of the anal sphincter muscles should occur in this. And that's what we measure, whether the rectal pressure has increased. Then we fill the balloon. That is, a small balloon then is inflated into the rectum, and the patient is asked to respond at first sensation of urge, um, and also the first sensation of something filling, urge, and discomfort. So this simulates the rector anal inhibitory reflex. So what will happen is an involuntary relaxation of the internal anal sphincter. Rectal compliance and sensation will also be measured. In fecal continence, patients will have generally low resting anal sphincter pressures along with weak squeeze pressures. In constipation, however, they will have high resting and uh, squeeze pressure, uh, contrary to the fecal incontinence. Then we also see in difficography, this is particularly important to identify, especially any associated pathology such as enterosil or rectosil. So the things that we can identify, and or the things that difficography is indicated, is number one, in chronic constipation. It can be sometimes used in fecal incontinence, because this will show about how much sometimes this is basically to exclude any associated intussusception or any associated enterosil rectosil. Incomplete evacuation, if the patient suffers from obstructive defecation syndrome, then we also use it. In rectal prolapse, when we visibly cannot see the rectal prolapse, then we can also do a difficography to um, clinically see it, to prove that is, so that we can treat the patient. Cystocele, that is bulging of the bladder into the vagina. Enterocele, bulging of the small bowel into the vagina and rectum. Rectocele, bulging of the wall of the rectum into the vagina. And also dyssynergic defecation, where certain nerves of the muscles of the pelvic floor fail to work during a bowel movement. And this pelvic floor dyssynergia is particularly important, as they do not do well with an operation. So difficography helps us to identify any extra pathologies. Treatment. Conservative management is the first line of management. And this is why we need to know what kind of incontinence the patient has. If the patient has diarrhea, incontinence associated with loose stool, then antidiarrheal medication needs to be given, and also bulking agents need to be given to thicken the stool. If the patient is suffering with constipation and then incontinence or sense of incomplete evacuation, then glycerin suppositories or rectal irrigation needs to be given. All patients needs to be referred to biofeedback or pelvic floor muscle training. If this doesn't improve with it, then surgical management can be done. Sphincter repair was usually very popular, but the long-term outcome is not very good, so it is only indicated in young female patients with the large sphincter defect. Sacral neuromodulation is commonly used, and it has shown very good outcomes, and there are multiple studies that has also noted its long-term efficacy, and which is known to produce at least 50% of the symptom improvement after using sacral neuromodulation. There is also a ACE procedure for patients who has spinal injuries. Um, that is also very good for them, but it's not for all type of patient. And if all else fails, we can do fecal diversion, which is an end stoma. This has been a summary of fecal incontinence. It's a short summary, and it is only used for revision. I hope you find this useful. If you want more detailed information about the chapter, please visit the podcast. Thank you for listening.